Hey everyone, today we're going to talk about the Valsalva Manoeuvre. So the Valsalva Manoeuvre is when there's forced expiration against the closed glottis, which increases our intrathoracic pressures, our intra-abdominal pressures, and our cerebrospinal pressures. It's important because it allows us to assess autonomic reflexes and treat hemodynamically stable supraventricular tachycardia. And as with all of these questions, it's also important because you might get asked it in an exam, so it's good to know about it. So to describe the Valsalva Manoeuvre, there's really 3 parts and 4 phases. On our y-axis, we'll draw our airway intrathoracic pressures. The second is our blood pressure in millimeters of mercury, and our heart rate in BPM. And then on our x-axis, we'll draw time. So to describe each of the components of the manoeuvre, essentially our airway pressure, or what initiates the Valsalva Manoeuvre, starts at the 10-second mark, and this is forced expiration against the closed glottis or against some type of resistance. So our airway pressure will go to about 40 millimeters of mercury, and in some textbooks it will say the intrathoracic pressure goes to 30 centimeters of water. And specifically, we hold it for 10 seconds. So you can see here, there's a sudden increase in pressures, it's held for 10 seconds, and then a drop in pressure. For our blood pressure, for the first 10 seconds, we'll draw normal blood pressure, and here we've drawn 100/80. And then at the moment that our increased airway pressures happen, there's a slight delay, but blood pressure will then increase. It will then sag and droop into a U shape and then increase towards the end of that 10 seconds, followed by a sudden drop in blood pressure with another increase in blood pressure and then a drop back to baseline at the 30-second mark. For heart rate, we have normal heart rate at about 80 beats per minute. Just after the 10-second mark, when there's an increase in intrathoracic pressure followed by the increase in blood pressure, there's a sudden drop in heart rate. This heart rate over the course of the 10 seconds increases. And then at the end of the 20-second mark, just after the drop in blood pressure, there's also a drop in heart rate, followed by an increase in heart rate that corresponds with the increase in blood pressure, and then a return to normal at the 30-second mark. So to put it all together, there's 4 phases. Now, phase 1 is the initial forced expiration against the closed glottis that raises our intrathoracic pressures and our airway pressures. So at the onset of the manoeuvre, there's a transient small rise in blood pressure with a brief fall in heart rate, and this is due to the transmission of the increased intrathoracic pressure onto the aorta. At the same time, the raised intrathoracic pressures force blood out of the pulmonary circulation into the left atrium and causes a transient rise in left ventricular stroke volume, which also helps with that increase in blood pressure. At the peak of that blood pressure marks the start of phase 2, which is also marked by the lowest point of the heart rate as well. So the raised intrathoracic pressures causes a decrease in venous return to the right heart that reduces cardiac output and causes a fall in the blood pressure. This fall in blood pressure stimulates baroreceptors and the reflex compensatory mechanisms are activated, leading to an increase in sympathetic drive, causing an increase in heart rate and peripheral vasoconstriction. These changes tend to restore the blood pressure and then once we reach a restored blood pressure and the peak of our heart rate, this marks the start of phase 3. And phase 3 is quite short. So immediately after the release of the positive airway pressure, there's a transient fall in blood pressure with a further rise in heart rate. And this is brought by the loss of transmitted raised intrathoracic pressures on the aorta and the re-expansion of pulmonary vessels, causing a small fall in stroke volume. Now, as we enter phase 4, with the intrathoracic pressures returning to baseline, the venous return is restored to normal, and then there's a normal cardiac output that results. The delivery of a normal cardiac output into the constricted peripheral vascular bed, though, leads to an overshoot of the blood pressure, which again stimulates the baroreflex in the opposite direction now, leading to increased vagal tone, leading to peripheral vascular relaxation, which drops blood pressure down, as well as a reflex bradycardia, which is important here to note. So if we were to just add this to some pathology, such as with congestive cardiac failure, essentially it's the same curves, but there's changes in the blood pressure and the heart rate. So in congestive cardiac failure, there's what's called a square wave response that's seen, where the blood pressure is elevated throughout phase 2 and there's no overshoot in phase 4, and there's little change in heart rate. The increased blood volume and raised peripheral venous pressures maintain venous return to the heart, given that the person is in heart failure with high venous pressures. And the raised intrathoracic pressure is transmitted onto the aorta, resulting in a raised blood pressure. Hence why there's this square sort of just sudden increase in blood pressure. There's no drop in venous return, so you don't get that U-shaped sloping. And this is the square wave form that you see. And then I mentioned it's good for testing autonomic reflexes. So if we take a group of patients such as diabetics, people with high spinal cord injuries such as in quadriplegia and any other autonomic pathology, you can also see changes in the response to Valsalva. So in these patients, there is an excessive fall in blood pressure in phase 2 and an absence of overshoot and bradycardia in phase 4. And this is because, as we mentioned before, in a normal person, the blood pressure increases partly because there's that sympathetic drive with vasoconstriction towards the end of phase 2, where these people have a lag or no response from that. Plus, they'll have the drop in preload, hence why the slope in phase 2 just continues to decrease. They also don't get that bradycardic response because they never had the increased blood pressure. So the heart rate will remain higher at that point, meaning that you don't get that bradycardic response. And the blood pressure, as you can see in phase 3 to 4, is this gradual just increase and then drop back to normal. So this vagal bradycardic response that happens just at around phase 4 is really important to note, because it's at this point that you have increased vagal tone, which decreases conduction via the AV node. And this is what terminates supraventricular tachycardias when you use vagal maneuvers such as the Valsalva Manoeuvre to try and get people out of the SVT. Thanks for watching. If you guys have any questions whatsoever, or anything you want me to cover, feel free to put it in the comments.